Hello, David. Are you still there?
Yes, Joseph, I'm here. Just a minute. I'm trying to put this up. Oh, can you see my screen?
Yeah, sure. I can see it.
Okay. Good evening, everyone.
Evening. How are you, David?
All is well. So, welcome to another Sunday. So, and whenever it's Sunday and the time is 8 p.m., we the roads lead to the same place. It's we meet through Google Meet and we discuss a case in order to keep learning medicine. So today I have a case for Joseph. I hope everyone will enjoy the case and learn from Joseph. So, Joseph, are you ready to start?
Yeah, sure.
Okay, so today we have a 50 years old male with diarrhea for 3 weeks.
Yeah, thank you very much, David. So, straight into the case because we've passed like 5 minutes and we've discussed diarrhea here before. And when you see diarrhea, the most important thing is the time frame. And then you have the 2 to 4 weeks cutoff, meaning that less than 2 weeks, we call it acute diarrhea. If it goes beyond 2 weeks, when it is between 2 weeks and four, you call it subacute, and then if above four, you call it chronic diarrhea. So this is subacute diarrhea, but the clinical breakdown approach of subacute diarrhea and chronic diarrhea is usually the same. And the most important thing again, when David will be presenting here, I'll be looking at this is subacute diarrhea. Are there red flags in these patients? Like, is there anything that shows this patient is inflamed? And those are things like weight loss, abdominal pain, bloody stool, fever, and the like. So, without wasting time, I think David, you should present the HPI.
Okay, so for the diarrhea, this patient presented with intermittent diarrhea, 2 to 4 motions per day. It was watery, of small volume, non-bloody, non-mucoid or greasy, and there was no foul smell. It does not improve with fasting. It was associated with mild periumbilical. dull aching, non-radiating abdominal pain. Uh, he reports persistent fatigue and loss of appetite, but there is no recurrent acute abdominal pain. He denied fever, jaundice, oral perianal ulcers, other GI symptoms, and he also did not report of any night sweats. He also reported of a 2 weeks history of skin lesions, which were multiple, flat, dark, or variable size. And so they started on the forearms, especially the anterior aspects, and the dorsum of hands, and then they went on to involve the neck, upper back, lower limbs up to the level of the shins. But they spared the face, the trunk, and thighs, and they were associated with peeling of the skin and ulceration on lower limbs. However, there was no itching, discharge, or nail changes, and he did not report any new personal care products. He does not report any allergies. He had no joint symptoms, muscle weakness, heat intolerance, palpitations or tremors, no sick contacts, and no drug use prior to symptom onset. So, review of systems was unremarkable. I think you can discuss that.
Yeah. So can I see the slides? I think this is a very intriguing case, by the way, just because there is a rash. So I love the rashes. Can I see the slide? Yeah. Yeah. Okay. So as I said, the most important thing here it will be to characterize to see anything that suggests this is an inflammatory diarrhea or not. And the thing that I'm seeing here is just this the periumbilical abdominal pain, nothing other than that. So it will be hard to say for sure it's really straightforward. This is inflammatory and go through that route. So I think I should carry both of them. Probably this can be non-inflammatory or inflammatory diarrhea, and move along with them. Maybe some stuff will be coming out. Who knows? Maybe in physical exam, because I'm not seeing that blood institute. I'm not seeing weight loss. I'm only seeing that of importance that David is reporting um, that this diarrhea is there, even if this patient is fasting. So it means it is not dependent on foods. That there are some areas, if you like load the GI, meaning a patient has eaten, and then they have a diarrhea. So it's the same principle when you have a heart problem and you load the heart, the patient exert and they feel pain. So it's the same thing. So that kind of diarrhea, it will tell you that that kind of diarrhea is digestive in nature. Maybe that there's some sort of digestive juice when they're coming out when patient is eaten, and then this patient start to have that diarrhea. But this is not so. It's not related to that. Um, Another important thing, I think. Can you move on? The next slide. Yeah. So okay. Before going to the skin lesions, so personally, if I see subacute to acute diarrhea, I say uh, inflammatory, non-inflammatory. Inflammatory, we have things like infections, autoimmune or cancer. The infections, you can have a TB of the intestine. Also, if you think of any infection, you think first, is this patient immunocompromised or not? So if they're immunocompromised, you also add some sort of things like imagine chronic diarrheas of HIV, things like Giardia and stuff. That's also important. Then autoimmunity, usually we talk about IBD, and then the malignancies of the colon. Or on the other hand, you have non-inflammatory diarrheas, things like digestive diarrhea, digestive disorder diarrhea, and stuff like that. So I don't have a framework connecting rash and diarrhea, but if you say this, my mind jumps out and think is this paragraph. People's paragraph will have a diarrhea and then they'll have a rash. But I'll be honest with you, I can't even recall how that a rash of paragraph looks like. So I'll have maybe to Google a picture and see how it looks like. We used to study it, theory stuff, but if you haven't seen stuff, it's hard to think about them. So my task now will be connecting um, uh, subacute chronic diarrhea with a rash. Apart from paragraph, maybe I'll see if I have other things, but I think we can move on for now.
Okay. Yeah. So we go to other components of the history. Yeah. So on medical history, this patient has HIV for 11 years on TLD. Yeah. So initially it was TLE and then switched to TLE based on or the entry of dolutegravir in the first line regime. And so currently he does 6 monthly refills. Latest CD4 count, which was done during the index admission, was or during the index presentation was 654, and the viral load was undetectable. As a previous history of an ankle fracture due to a motor traffic accident about 6 years back, and fixation was done. That is internal fixation with good recovery, no chronic illnesses like hypertension or diabetes. On family social history, so he consumes alcohol for more than 20 years, about 20 units per week. And that's a combination of beer, spirits, as well as local brews. And on cage assessment, he scored 3 out of 4. He's the firstborn in a family of 6. All siblings are doing well. He's separated and he lives with relatives. Uh, yeah, so maybe you can discuss that.
Yeah, can I see the first slide that you presented? Yeah,
I
so
think it was this
yeah,
one.
so yes, so that's very very important. Any person uh, chronic subacute to chronic diarrhea, immune status is important. So HIV of most importance in this area that we're living. But after you do the HIV, you ask yourself because with the help of science, these people can lead a normal life. So that's why here they did CD4 and VL, the viral load, and you realize this person, the HIV is just there, but when we combine it to discuss about diarrhea, this is like I'm discussing for what I believe now. It's like I'm discussing diarrhea to a normal person because CD4 600 and the detective viral 6 month refill. It means the HIV is well controlled. This person at this moment is not immunocompromised, so that won't be helpful. Um, Next, yeah. So the issue of alcohol is also very very important. Of importance to think of alcohol and diarrhea is diseases of the pancreas. So chronic pancreatic insufficiency will give you chronic diarrhea at the end. But again, it doesn't look like this because this is the diarrhea that when you feed is when it becomes severe. But this patient, even if when he didn't feed, it just had diarrhea. So 20 units per week, if that calculation is correct or not, but it already tells you this is a bit higher because I think in the males the cutoff is usually so I think it's 3 per day and then 21 per week. So 20 units per week, 21. It's not that far. So I believe this is high. And then uh, some stuff should be considered here. I don't remember what even KG stand for. David will have to remind me. But you're telling me this patient is taking 20 units per week. I say this might be taking a little bit higher amount of alcohol than what is recommended. Um, so another thing is, as I said, if you tell me chronic diarrhea rash, I think of pellagra, and pellagra is the because of the deficiency of one of the vitamins. I believe is B something, niacin. I don't know, but B3 or something. Yes, I think it's B. Someone can check me up. I think it's B3, the niacin. So chronic alcohol intake may lead you into deficiency of some vitamins because you're drinking alcohol and not eating. The absorption is poor, and you're not getting in the enough macro and micronutrients. So this is also very important. Can we move on?
Yeah, so that's it about the components of the HPA. I think next we'll move on to physical exam. Should we proceed to physical exam?
Yeah, yeah, we should.
Okay, so on exam, this patient was fully conscious. He was not pale, not jaundice. There was no lymphadenopathy. He had no stigmata of chronic liver disease. No edema. Vitals were within normal limits. So here is the skin exam. So I'll let you take your time, and when you're ready, just let me know to move on to the next one.
Yeah, yeah, sure. We can move on. I can describe them later.
Okay, so here is another image. Another image. So for other systems, yeah, and you told me to remind you something about cage. So cage is used to assess if someone has alcohol use disorder. So uh, so the systems for cutting if someone has tried to cut their drinking without success. So they try to cut, but they fail. So that is the C. And then A is if someone is getting annoyed by other people telling them to control their drinking. And G is about feeling guilty about their drinking, and the E stands for eye opener. So when someone drinks alcohol first thing in the morning. So this patient scored 3 out of the 4. So what was missing was the E. He was not drinking alcohol first thing in the morning, but 3 out of 4 already suggests a high likelihood of alcohol use disorder. Yeah, so coming to apart from the skin exam, so the other systems, abdominal exam was normal, CVS was normal, respiratory system was normal, musculoskeletal normal. So for neuro, GCS was 15. A mini mental status exam, he scored 24 out of 30. Cranial nerves were normal, coordination and gait were normal. So that's exam.
Um, yeah. So can you remind me, is the MMSC 24 out of 30, is this normal?
So the 24 is mild,
Okay.
mild cognitive
Yeah, that's
impairment.
very important. So let's go to the rush. Yeah. So what I'll be doing in this patient, if I'm seeing him, I'll close my eyes and palpate this rash because it's important. When it is palpable, you call it with this big, you call it a plaque, and then when it is not, you should call it, I think, a patch. So I think this is palpable with my subconscious palpation. I think this is palpable. So I can say this patient has a hyperpigmented patch, is hyperpigmented plaques on the neck and then the shoulders, and then I've seen there are wounds, right, on the on the feet. Let's see the next one. Yeah. So yes, there are also the same kind of rash in the feet, but there also um, like the ulcerating rash down here, like ulcerating rash, the same kind of rash, but they're ulcerating. So yes, I said it's been so long, but yeah, this is typical rash for pellagra. And the neuro exam is also important. That's why I had to ask about that D, because I remember they used to talk about three Ds, like so they say diarrhea, dementia, and I don't know what's the other D. I forgot the other D, but diarrhea, dementia, and then there is something else they talk about. Yeah, so I think my job, David, is not hard today. This is if you recognize the pattern, see stuff, and you say, I see nothing coming close to pellagra. But if I say to pause and think of another thing, if someone sees a rash in a patient with HIV, they can think of other thing. Most important, because we see a lot of people with HIV around here, is Kaposi sarcoma. Kaposi sarcoma can also give you diarrhea. When the Kaposi is also in the in the GI. But you realize this doesn't look like the rash for Kaposi. The color for rash for the Kaposi is usually I don't know how to describe what the color is, but well, okay, when I see it, I can tell it. I'm not good with describing colors, so it doesn't look like it. Another rash in a patient with HIV. Yeah, but again, you should think, if you think of those senior Kaposi is also someone who is the HIV is not well controlled, but this patient is well controlled. So I think I can decide to like say this is a normal person. The HIV shouldn't be taking me away from considering this as pellagra. Other differential diagnosis, no, I think no. So the also important thing is that the patient's abdominal pain, the patient abdominal exam is also normal. So you prepare the abdominal patient who has a subacute to chronic diarrhea and it is normal. That's a very important finding, because if it was feeling tender, the job would be harder, because say she would start and say something is hurting, something is being inflamed inside of this patient. The large bowel, the small bowel, the vessels inside the abdomen. But that's not the case. That's not the case. So it's either um, maybe something from digestive juices, which is not true because patients stop eating but still they're having diarrhea. Deficiency of something, which is what I'm considering pellagra vitamin niacin. Someone has already checked me, I think, but I think it's B3 or something. And yeah, that's where I am, David.
Okay, so we'll go to the labs. Interesting discussion. Yeah, so here the labs, we do not have anything much. So here is the CBC. So what I highlighted, I tried to highlight what seems abnormal for me. Otherwise, stool analysis was done, electrolytes, creatinine, BUN, urinalysis, a stool analysis, as well as liver enzymes and some liver function tests, pancreatic enzymes, which were all within normal limits. CSR was normal. And then an abdominal ultrasound was done, which reported extrahepatic biliary dilatation. However, they did not report any calculus. The pancreas, liver were reported to be normal, and uh, other parts, also including the kidney, were also reported to be normal. So, if you can discuss those, and this is why you commit to a diagnosis.
Okay. Yeah. So the labs, uh, nothing because that 11. If I have seen this patient a couple of times,
Oh, Joseph, if you are speaking, you are muted.
yeah, sorry. So I've said the labs were unremarkable. If I was seeing this patient, I would go back and see what was the HB before. The machine can say low, but this patient is usually on 11 every day. You see him. But again, most common cause of anemia, you don't know what's happening. Even if the the um, it is normocytic, you should also send iron and see. Maybe it's the patient who drinks a lot, they don't have iron, they don't eat well, they don't have iron, and then they have that anemia. So that's not most important. The important thing is a normal ESR. This patient, normal ESR, again increases our suspicion that it's not inflamed. So it's maybe a deficiency of something, a drug that is using that's causing diarrhea, which we haven't been told. The drug that is having for the HAR, the ART, HART, they usually for some time they're there, and uh, a deficiency of any digestive enzyme, not really, because as we're seeing, when you're seeing a patient with chronic pancreatic insufficiency, you can send an amylase into this normal, and it's just still possible, it can be there, but again, this case doesn't have a flavor of that sort of thing. So the most important thing, again, we're being told of this ultrasound, and then extrahepatic pancreatic dilatation, right, David?
Yes, right.
Yeah. So let me reflect on that. Um, can I see that ultrasound again so that I'm not missing anything? Yeah. Extrahepatic beer dilatation and no calculus. uh, if you have, you have the liver and then the biliary system, it takes bile from inside the liver and then drains it out to go to the to be used in the duodenum and stuff like that. So if you have an extrahepatic biliary dilatation, it means something is blocking the CBD. That's my take. That's my take. So the things that can block a CBD, they can either come outside of the common bile duct, inside of the common bile duct, or on the walls of the common bile duct. So from inside the common bile duct, the most common, you have a stone. It's not surprising ultrasound can't see a stone because it is not the imaging of choice. So if the suspicion for stone is high, you do, I think, ERCP, where you can do also management, or MRCP, where you can see the stone. But can it be a stone? I don't think so, because it doesn't tally with anything that we are seeing here. An asymptomatic stone, unheard of. And then we would have see some symptoms: abdominal pain, maybe jaundice, itching, and stuff like that. So the other thing that can be there coming from inside, it can be a sludge. A sludge is it's not really a stone, but it's in the way of becoming a stone. It's like a porridge, something heavy bile that can sit also there. Another thing that can come inside, very rare, never seen a case, read case about that. Parasite called fasciola hepatica can also sit there. I don't think so. This cannot be, doesn't tie, it won't explain the rash and everything. And then on from the wall, you can have inflammation from the wall. So autoimmune diseases maybe can also do those sort of things. We have two that can be remembered, and I think the PBC and PSC. I think they stand for primarily biliary cholangitis or stuff like that, and then and the PSC is primarily I don't know, sclerosing cholangitis. So again, it's not the flavor. You have a patient who each is a lot. It's not the thing. From outside, you can have you can have Uh, you can have a tumor on the head of pancreas. They can also block their gain. The doesn't at all fit with that category. Or you can have a lymph node growing from elsewhere and fit there. So I don't know, but imaging abdominal ultrasound is an operator dependent. What he's seeing and the doctor you are interpreting the results doesn't tally, but this doesn't take me away from what I'm thinking about. This is a rash of pellagra, and the patient is having a rash in chronic subacute diarrhea. Whether they should be uh, investigated further, I think the next thing will be to do an MRCP and seeing what's causing the dilatation. Or maybe the dilatation is not so severe that the patient hasn't started presenting with symptoms, but maybe they have a slowly growing tumor on the head of pancreas that you can see, and you can take care of it before it causes the symptoms that we usually see in such kind of patients. So I think, David, what I have in mind, my differential diagnosis about chronic subacute diarrhea and a rash like that, apart from pellagra, I have zero other DDX. So I'll say that's pellagra.
Okay. Thank you for the interesting discussion. So I did not attend this patient. So he was attended by another team, but then I just got interested with the case and thought I should present it here for learning. So yes, thinking was the same, pellagra, and it was diagnosed clinically. The patient was initiated on treatment. Maybe Joseph, if you um, what do you think was the risk factor or probable cause of the pellagra in this patient, and how would you go about treating him?
Yeah, so I think it's the alcohol. Last time, as I'm saying, I read Pelagris Justin's theory. I think it's the alcohol, and the way to treat is to repress the niacin.
Yeah, so this patient thinking was the same. So there's a number of issues. Actually, I think alcohol tops the list because of a number of mechanisms. So one of them being this patient, because he also has alcohol use disorder, and therefore he probably is not taking enough nutrients, and therefore that predisposes him. But it also, there's a number of other mechanisms, because pellagra, as we are going to see about niacin in teaching points, uh, can also be synthesized or produced from tryptophan, which is an amino acid. So alcohol can lead to pellagra through a number of mechanisms. So that is probably the commonest mechanism. But another issue was the HIV, because there are also some case reports which have been reported of pellagra presenting in HIV patients. But then this patient was seemed to be immunocompetent, we could say. Just that, with HIV, maybe even the CD4 count, it could be normal in quantity, but then maybe defective in quality. But otherwise, the patient seemed the patient seemed otherwise well. And many cases of pellagra in HIV patients which have been reported among those with low CD4 counts and high viral loads, which was in the case with this patient. So I just put a few things here about pellagra. So it's caused by deficiency of niacin, or so the other name is vitamin B3, and they are it's either nicotinic acid or nicotinamide. They are both forms of niacin. And niacin is an important coenzyme in the synthesis and metabolism of carbohydrates, fatty acids, and proteins. So you've heard about NAD, nicotinamide adenine dinucleotide, and NADP. So you add the phosphate. They are very important coenzyme in many reactions, especially reduction oxidation reactions or redox reactions, in short. And therefore, it plays a crucial role in metabolism of a number of macronutrients. And niacin is widely distributed in plant and animal foods. But then the catch with plant foods is that the form we need sometimes, uh, because of the same issues that we talk about in other micronutrients, you find that it is bound to hemicellulose and other complex structures which reduce the bioavailability of the vitamin. But plant and animal foods are a good source. So clinical presentation, just like I saw, there were just two comments in the chat, and they were to the point. So clinical presentation is diarrhea, a photosensitive pigmented dermatitis, especially in sun-exposed areas, so which was very typical in this patient. And this patient also had a casal necklace, which is this hyperpigmented rash, you see it involving the neck. And so clinically, we remember it by using the 4Ds. So the 3Ds are diarrhea, dermatitis, and dementia. You remember this patient had mild cognitive impairment, as demonstrated by an MMSE score of 24 out of 30. But when we talk of, so dementia is put there just to for remembering, but the neurological presentation is varied and can include an encephalopathy, dementia as one of them, anxiety, insomnia, and many other neurological symptoms. And then the fourth D, which we did not include here, is death.
Mm.
So that is, if you remember reading your theory, we say pellagra is one of those diseases, one of the very few diseases, if not maybe the only one, in which death is a cardinal manifestation. So without prompt treatment, pellagra ends up in death. So the 4Ds are diarrhea, dermatitis, dementia, and death. So so the risk factors commonly, so as I said, alcohol use disorder is one of the major risk factors, especially in developed countries. But we also think it was the case in this patient. So others are like a history of bariatric surgery, for example, or bypass surgeries in general, which lead to a lot of micronutrient deficiencies. And then patients with anorexia nervosa or malabsorption syndromes, including some which Joseph have alluded to in this presentation. And then also there are some other conditions. So for example, you can have niacin deficiency in carcinoid syndromes with a number of medications. I talked about medications in the HPI. So isoniazid leads to a deficiency of pyridoxal phosphate, which is important in the metabolism of niacin, including the conversion of tryptophan to niacin in the liver. And therefore, with isoniazid, you can also end up with pellagra. So those are some of the risk factors. As I said, HIV is another one. And then especially in countries where the carbohydrates are main staple. So literature mentions countries like India, China, and also sub-Saharan Africa, where they eat carbohydrates which are not fortified with nicotinic acid. It's still a little prevalent as compared to countries, for example, in Central America, where they also eat carbohydrates, but then the mechanisms of preparation increase the bioavailability of niacin, and therefore it's not very prevalent there. So treatment is administration of is replacement of the vitamins. So for example, this patient was given a multivitamin, so initially IV and later on kept on on a vitamin B complex, on an oral multivitamin, which uh, ensures adequate supplies of nicotinic acid in the form of nicotinamide. And therefore, I did not include after photos, but just 8 days after initiation of therapy, this patient improved tremendously. Diarrhea stopped completely, and the skin rash or the skin lesions started improving. So this case reminded me of a patient I saw as a resident. So when I was rotating in gastro, there was one patient who presented with diarrhea, and then diarrhea and the dermatitis, and of course the patient also had features of dementia. So by that time, I think because of maybe these are forgotten diseases, but so pellagra is said to be forgotten but not gone. But we had a suspicion of pellagra, but we were too late, because when we're in the process of trying to find if we can get access to nicotinamide, this patient collapsed. But so later on, we thought maybe we could have given a multivitamin, which has so for example, brands like Nat B or Neuroton, I think especially Nat B, it has about 50 milligrams of nicotinamide, and what you need is a dose of about 100 milligrams per day. That will be sufficient replacement. So this patient was kept on IV multivitamins and later on oral, and he improved. Diarrhea disappeared, and the skin lesions started improving. So uh, that's what I had for you today. So Joseph, any reflections from you? And
Yeah.
kudos for getting it right. I think right from the second or third slide. So for those who do not know, that is what is called the pattern recognition. You just you see a constellation of symptoms, and then you have a diagnosis right away. So that was very good of Joseph.
Yeah, thank you for this case. This is a very good case. Yes, I think the case that you saw as a resident, you were telling us, and I think that's the reason why we studied this disease. But to be honest, I've never seen such a thing. But yeah, so as I'm doing this clinical reasoning day after day, I'm learning that it's not so much about the knowledge. Knowledge is very important, but the main part of reasoning is recognizing the pattern, like multiple things, and then you think, what can it be? You connect, you have your schemas of this and this, you find the intersection, you find out what is going on. Thank you very much. The chart, I was not looking at it, but the I blanked on the 3Ds, and but then you told me here, and then the how the rash is called. That's very nice. You guys knows a lot. Thank you, David.
Yeah, thank you, Joseph. So we still have some minutes. So if there is anyone who has any comments, any questions to Joseph, any experience that you would like to share, this is the time. And at this point, I should acknowledge that I've already, so Roland
So
promised
sorry,
to
David.
bring a
Sorry,
case.
David.
Yeah, yeah,
Before I
come first.
forget.
Yeah.
So, how did you account the dilated extrahepatic biliary tree?
Yeah, so that one that one was I did not find any explanation for it. So you remember I also presented a case here last time that was dengue with warning signs. Remember that
Yeah.
there was also a report of dilated,
Mm,
yeah, extra hepatic, I think,
mm,
biliary ducts, but then uh, nothing significant came out of it. So I did not find any explanation for this.
okay.
And of course, after the patient improved, the best we can say is uh, treatment and then improvement is also part of diagnosis. So the patient improving
Mm,
with provided treatment after clinical diagnosis, we think maybe that was noise rather than signal.
exactly. Yeah.
Yeah.
Exactly.
Yeah, so I acknowledge receiving a case from Roland, and I think we'll work on it with Roland and present it in the few coming days. So because I've already seen the case, I think this will be for Joseph and anyone else who would be willing to discuss. So
Fabian will be willing, right, Fabian?
yeah, that will be amazing. So either Fabian alone or maybe you can go as a team to discuss Roland's case.
We can go with Fabian.
Okay. Okay.
Okay, that will be awesome. So I will also spend this opportunity to ask others. I'm hearing an echo. I'm not sure where this is coming from. Okay, it has disappeared. So uh, I look forward also to other people presenting cases, bringing cases just like Roland has done. So I think that will be interesting to see cases from other people. So for these remaining minutes, maybe I'll welcome the floor. If there are any questions, comments, or any experience to share, we still have some minutes. Welcome. Okay, I do not see any hands up. Joseph, is there anything else from you, or should we close the session?
Yeah, I should also thank Roland, one of the people who are also the frequenters here, and he also told me at one point to bring the case. So that would be amazing from him because he's a resident. He sees a lot of patients than me probably, and he thinks about the patient more than me probably. So that would be very interesting, and I wish everyone will come and listen to that.
So if there is nothing, I see no hands so far. So if there is nothing else, hope to see you next weekend. Have a good night.
Good night.